I'm delighted here to be introducing you to Dr. Guillaume Fontaine, who is a new recruit in the Ingram School of Nursing at McGill. He's entered into the tenure track after having done his postdoctoral studies out in Ottawa, and also a scientist at the Jewish as well. When I finished my PhD, I had no training in implementation science. I tried to do this, and I was very, very much delighted that we have in Montreal a leading expert in the field who can really help coach us and guide us and provide us the methodology that is needed to get this innovation into practice, but to think through, it's the approach. You could think through how do you get all kinds of sources of evidence into practice. And so a gem of a resource here for us. And let me see about the other stuff, about the bio. Let me see what else we got. We have that you are the PI at the Center for Clinical Epidemiology at the Lady Davis Center for Medical Research, affiliate Center of Implementation Research at the Ottawa Hospital, scientist I mentioned at the Jewish, and what I like is that he's a visiting fellow at the Kirby Institute in New South Wales and Sydney, so maybe there's opportunities to take your students to Australia every year.
Maybe.
We could see. As an implementation scientist, Dr. Fontaine navigates the complex terrain of bringing scientific advances to everyday use, devising strategies to overcome barriers, and ensure that the research findings are effectively enhancing the healthcare and societal outcomes. So with that, I'm delighted that you're here with us for the day and to share your insights. Thank you.
Great, thank you so much, Audrey. You can hear me properly and online too, I would expect. So let me just bring this.
Oh, keep forgetting that, sorry.
Closer. So I'm super excited to be talking about implementation, and a little bit of what we're going to be doing is a bit of a crash course, Implementation Science 101, and what are the principles that can be leveraged from implementation science to promote the uptake of VR. So we'll see what is applicable and what's easily translatable. So I have no conflict of interest to declare. So just a bit of background. So I'm an implementation scientist, so I focused on the different methods and theories that can be used to promote the uptake of evidence-based interventions, such as VR, but in different clinical domains. And my ultimate goal as a researcher is to narrow the gap between knowledge and practice, improve the quality, efficiency of healthcare, and equity as well. A bit of what I do at McGill, so I lead the RISE lab, so Research and Implementation Science for Healthcare Engagement, Effectiveness, and Equity. So I do mostly implementation science research around infectious diseases to promote the uptake of testing, treatment for viral hepatitis, STIs, COVID-19. I study also the interplay between health equity and implementation. So how can we make sure that marginalized populations benefit from innovations, like all groups in society. And I also study the different methods that we use within implementation science to make sure that we can bring new innovations to practice. I also do implementation research in other clinical domains like oncology, chronic diseases, digital health, and I use a wide range of approaches, so qualitative methods, quantitative methods, so it's pretty diverse. So we'll be covering a few topics. So we'll have essentially kind of two parts to the presentation. So first part of the presentation that I'm doing right now, and then an opportunity to break out in small groups and discuss some specific aspects, and then another part of the presentation, and then another part of group discussion. So we'll be kind of having maybe a foundational overview of implementation science and different concepts, thinking about the barriers and facilitators to implementation, and then thinking about the implementation strategies. So the strategies that we use to overcome barriers to the use of VR and amplify facilitators, because we have a lot of facilitators that are present also in the settings, not just barriers. So we have to keep those in mind when we develop plans to promote the uptake of VR. So 101 on implementation science. So why is implementation science needed? So of course, I guess the main justification of implementation science, it emerged from some guidelines, some clinical practice guidelines that were developed, over the course of the 90s, the 2000s, that were not, in routine practice. They were not implemented. So I guess the first care gap that's addressed by implementation science is the slow uptake of interventions and practices that are effective, that we do have some evidence that they're effective, like VR, you know. We've seen today from a few presenters that we have a good evidence base for the use of VR in many different clinical domains. So I guess VR falls to me a bit more in the first category of this graph. But we can also leverage implementation science to de-implement some practices that are harmful, you know, for example, doing too much x-rays for low back pain in the emergency departments. So this is an example of practice that should be de-implemented. In some cases, we also have trouble keeping up with the pace of evidence about existing interventions. So we use VR in a given setting, for instance, and then the protocol for VR is changed. How, you know, should we adjust the implementation process and the practices to reflect the new protocol? So this is an existing intervention, and that we just want to change the way that it's delivered. And then another gap is the inequities in care, right? So some populations might benefit more from VR than others, but in some cases, the populations that would benefit from VR, well, they're not engaged in care, or we're having trouble, you know, reaching them, and, you know. So these inequities, we can also try and address them leveraging implementation science. And I guess the last kind of care gap that implementation science can help address is change in clinical ethics, so the ethics of care. So sometimes, you know, we don't have 25 different studies showing that an intervention is super, super effective, but we know for ethical reasons and moral reasons that we should change care, like doing some advanced care planning and like some other types of interventions that we should implement for moral reasons. So these are the different care gaps that implementation science can help address. And usually the approach that we take is the Isla Jat approach, you know. So it seemed like a good idea at the time. You know, we tried that strategy, and when we talked about that first strategy, we thought it was a good idea, you know, we tried it, but then in the end, you know, there wasn't really the uptake of the intervention, or, for instance, it worked first, and then there was a drop-off in the use of the intervention. Like, I think it was Argerie who said, you know, at first, you know, VR in some settings it was super used, and then maybe there's a drop-off. So implementation science can help us think through strategies for the initial adoption of VR, but also the sustained use of VR, because the strategies can be different, you know, they're not the same. So implementation science can essentially overcome some of the limitations of this expensive version of trial and error, where we don't build on evidence, and without implementation science, sometimes you don't see the full scope of factors that might influence the implementation. So you miss out on some barriers, and you're not aware of the full range of strategies. A few typical approaches to implementation. So the first one that's very common is develop and issue guidelines, you know, like the 10 Commandments. So this has to be done and it'll be done, you know, but it's not always as easy, right? They do not self-implement. Then the second approach is often, okay, well, we'll throw a bunch of strategies together and see what sticks and if it works. But we have evidence to show that more strategies is not necessarily better. So we have to pick and choose the right strategies for supporting clinical practice. Then you have, I guess, choosing a favorite solution, like always with a hammer, but it might not be the best solution for the given context. And you also have often training, education, developing an app to promote the uptake of, for instance, VR, you know, but it might be that the content of the training is not tailored to overcome the barriers, you know, so we also have to think about that. So in 1997, so quite some time ago, there was a leading researcher, Richard Grohl in BMJ. He said evidence-based practice should be complemented by evidence-based implementation, right? So we have evidence-based interventions like VR, and then what are the evidence-based implementation strategies that we're going to use to promote the uptake of VR? So this has become a huge focus within the field of, you know, medical research over the last few decades, and essentially it kind of coalesced around implementation science and kind of the science of how we look at implementing things. So if we contrast, I guess, the Isla Jat approach versus the implementation science approach. So, a traditional approach would be, okay, we brainstorm, we pick a solution, we use that solution, whereas with implementation science, we're thinking more around the barriers. We're thinking more around the context of implementation, and then we'll go on selecting a strategy. So just quick definition of implementation science. So implementation science is defined as a multidisciplinary specialty that seeks generalizable knowledge about the methods used to support the integration of intervention, programs, and policies within healthcare systems. So what's interesting about implementation science is that it builds on decades of research in psychology, sociology, organizational theory, behavioral economics, nursing, and other domains to look at, essentially what is the evidence on how we identify the barriers and what is the evidence on the best strategies. And then it's essentially a wide menu of possibilities which are evidence-based, so we have good evidence on the effectiveness of some of those strategies. I really like as well the definition of Anne Sales on what is implementation in itself. So Anne Sales is a leading implementation scientist. She's also a nurse. She's based in the United States. So she says that implementation is the process of planned human behavior change under organizational constraints. So if you want to implement VR, you know that you're going to have to do it, you're going to plan the process. It'll be a planned process. You're going to have to change the behaviors of people, within the setting, right? So it'll be changing the behaviors of clinicians or maybe managers, of patients, people at different levels. And you're going to have to work on some organizational context and constraints. So if you keep in mind those aspects when you start planning your effort of implementation, then you have more chances of success, right? And you have implementation science, which is the generation of knowledge within the field, but you also have implementation practice. So what we're going to do today is a bit more focused on implementation practice, because we're going to be using the tools generated within the field to kind of see how they might be applicable to promote the uptake of VR. And I thought this is interesting. So we call this the implementation subway, I guess. And essentially, when can we implement an innovation? So first, they say, you identify the practice of interest, and then, in this case, VR. And then you look at how has the practice shown efficacy, so, effects under controlled conditions, on the reduction of pain, for instance, or something like that within a lab in a controlled setting. And then has the practice of interest shown effectiveness, so effects within a real setting, like on a care unit or in a clinical context. And then usually you look into the implementation piece. So we're kind of around the implementation piece right now for VR. And then you can do different types of research, or you can essentially, if you're not doing research, you can then use the strategies to implement VR and assess the barriers and facilitators, like I was saying before. So a few additional concepts in implementation science. So you can't really do any, sorry, some of my slides are in French, I think just a few. I'm always translating back and forth slide decks. So, so you can't really do implementation and implementation science and implementation practice without the proper tools. So you need to have some tools to do implementation properly, because those tools, they build on evidence and they're associated with some resources as well. So if you want to have access to the proper resources, you better use some of those tools. I'll focus on two of those categories. So a landmark paper around 10 years ago by Per Nielsen, he's a Scandinavian implementation scientist. He talked about the different approaches that we can use to promote the uptake of evidence-based practice, and he presented different types of models. So essentially, the first category is the more well-known, I would say. So it is the process models. And a really simple example of a process model is this. So first, identifying what is the problem, what is the solution, and who needs to do what differently. So the problem, for instance, would be, okay, the management of pain in children is ineffective, and then the solution could be VR. And then if we want to promote the uptake of VR, who needs to do what differently? Who are the key actors within the setting? who need to change their behavior to make sure that VR is used sustainably. And then the second step is looking at the barriers and facilitators. So looking at those different actors that are within the system. What are the different barriers, the facilitators? And then we look at the strategies. And if we want to do it, we can also go to step 4 and measure and understand implementation. So in terms of the problem, so this is usually the first piece. I think the problem and what we want to implement today is pretty clear. We don't need to linger on it. But I think the context of implementation and how we implement VR is interesting. So VR is one thing, but for which clinical condition, under which context, and then which setting, and who's going to be doing it. And so we have some aspects that we need to clarify about the context of implementation and how the solution is going to be used. So I guess that's the first piece, So what is the problem and the need? Who is impacted by the problem? And that we do have to think about. So we have a QR code that I'll show you a few slides later. And Arjuri and Sophia, they generated a great implementation plan template that you can fill out on your phone with different questions. So I'm going to be presenting some of those questions that you'll be able to fill out when we have some breakout discussions sessions. So for instance, identify what is the need that you're trying to fulfill with VR, and then you have some additional questions around, for instance, your practice setting, the approaches that are currently being used in your setting that would be optimized with VR, and other types of questions that are related as well. What outcomes are you hoping to achieve with VR? Who will be impacted by the use of VR? What would be the likely acceptance and willingness of those impacted by VR use? And then I guess what comes next is, and we'll be going back to those questions in the survey with the QR code. But before we do that, I want to talk a bit more around the who needs to do what differently piece. So when you think around implementation, you have to think about all of the different actors involved in implementation. So everybody has, of course, a say in or should have a say in implementation, or like a voice. So starting from the recipients and the people who would benefit from the innovation, the patients and their families, and then the providers. But you also have to consider who will be the champions for the delivery of the innovation, who is going to be involved at the level of the middle management, senior management. Also consider who is going to be on your implementation team, the different members that would form your implementation team. And then you have some linkages as well with potentially, if you're going to evaluate your project, the evaluation team as well. So we have to think about all of those different actors when we think about the implementation of VR as well. So it is a who needs to do what differently, but I would say we go a bit further than that. So it's who needs to do what differently, when and where. Because when we talk about differently, for instance, in some settings it could be that you already have VR and that you want to use it for a different clinical problem, or you've already implemented VR a few years ago, and then you need to promote more uptake, more use of VR by maybe the setting. So it's also about clarifying the gap when you're thinking about those questions. So is it about starting VR? Is it doing more of VR, doing less of some interventions and replacing some interventions by VR? So kind of thinking around, okay, what is the problem and what exactly are we trying to do with this, with VR specifically? So like I said, we're still thinking about the problem, still thinking about what needs to be done and when and where. And speaking of when and where, that needs to be defined as well, So is it, you'll be using VR at every opportunity, you'll be using VR, within some protocol or when some clientele shows up. So that needs to be defined as well. And also thinking about the physical location of where that will take place. So will it take place, in a dedicated setting, in a room? So that also needs to be considered. One tool that I like, we won't necessarily be using it today, but it's a really useful tool. It's called ACT. And essentially, you can use it's called action, actor, context, target, and time. So when you're thinking about implementing something, you need to, like I said, think about the different actors. So for instance, the nurse, the nurse is one of the key actors. And then what would she be doing in relation to VR? So I guess, engaging the patient, providing some information, making sure the equipment is set up properly. That could be different actions that she would be doing. In which context would she be doing it? The target would be the patient. And then when would she be doing it? So, over the course, it could be every day, it could be, on demand, it could be, it depends. And then the idea is to kind of use that for different people who are involved in the implementation effort. So you could say, for instance, this is an example, we do this with hand hygiene in hospitals, of course, which is a kind of a pervasive issue. And then think about, okay, well, here are the different actors. We have the physicians, the nurses, we have the cleaning staff, the hospital administrator, and then they all have different actions to do, which are a bit different, but they're all, important to consider. So I guess why are we, specifying those behaviors is because we want eventually to think about the barriers for each of those actions and each of those actors. So we often start with, nurses and the providers that are front and center, and then we move out to the other actors. So patients, nurses, and the frontline staff, and then we kind of, if we need to, we broaden out the circle to look at barriers more broadly. In some cases, we'll do, interviews with people in the ministry, but it's not always relevant, of course, for the implementation of something. Sometimes you just need those few people to be involved in the evaluation of barriers and facilitators. So thinking about the actors, thinking about what the actors would be doing. So I guess that's the first two pieces that you'll have to think through. And then you have a few questions as well in the survey around that. So, who should be involved? Who should be on the project team? What key skills would they be bringing to the team? The responsibilities, for instance. How often should the implementation team meet? Do you need external consultants? And other related questions. So I guess this is kind of the first piece that we put together. So we have a QR code for, sorry about that. A QR code for filling out the implementation plan, starting to fill out the implementation plan. And I think the first piece would be, like I said, discussing amongst the people at your table, who are the key actors, who would be involved in delivering, promoting the uptake of VR, what would be their roles, what would be essentially the things that they would need to do as well. And then you can answer the first few questions of the survey. So you have essentially the first few questions around the need for VR, who would benefit from it, and then who needs to do what differently to implement VR in your practice setting, thinking about the different actors. So around 20 minutes for discussion, and then we'll get back into a second period of presentation with, I guess, talking more around the barriers and the different implementation strategies that we can use to promote VR. Okay, so the barriers and facilitators to change. So that's, one of the key tenets of implementation science is that now we've looked at step one, but step two, So what are the barriers and facilitators to the implementation and use of VR? So for that purpose, we use a tool called the Theoretical Domains Framework. So what is it, this tool? It is a tool that's been developed by leading experts in behavioral science and implementation science, decades of research in psychology, and essentially it synthesizes all of the influences on human behavior within 14 domains. So essentially, if you look at this list of 14 things, you can pinpoint and categorize the barriers to VR use. Starting with the most well-known, knowledge. So of course, lack of knowledge is often a barrier. That's pretty, self-explanatory, but also skills. So lack of skills to use VR. Then you have social, professional role, and identity. So this one is a bit trickier sometimes, but it is focused around is VR, are nurses and different providers perceiving that VR fits within their professional role, their tasks, what they have to do? If they perceive that it is aligned with their professional role, they're more likely to use VR. So this is another key domain. You have beliefs about capabilities. Do people feel like they're able to use VR? Yes or no? Optimism, are they big optimists, or in contrast pessimists about the technology and technology in general and VR? And then you have beliefs about consequences. So that speaks to essentially, do people perceive that there's benefits to be derived from the use of VR? Or in contrast, do they believe that using VR will have some negative consequences, will increase workload, will cost too much, so what is the balance of these benefits and drawbacks of VR that people perceive? Reinforcement is whether some positive experiences regarding the implementation of technology in the past reinforces the fact that people are likely to implement a new technology like VR. So do they have positive experiences in the past that reinforce whether they're likely to do it again? Then we look at intention and goals. Do people have the intention of using VR? What are their goals? Does using VR align with clinical priorities, for instance? We look at the memory, attention, and decision-making process, social influences, emotion, and behavioral regulation. So behavioral regulation is just essentially different strategies that are deployed to help people use VR. So what we do generally is to ask, if we're going to do it in a research context or not in a research context, whether we just want to implement a new practice, where you can do interviews, focus groups, you can ask those questions in one-on-one discussions, you can guide email conversations, just inquiring about what people think, what are the resources available. And essentially, the TDF, the Theoretical Domains Framework, can be used to structure how we think about barriers and facilitators to implementation. So we've provided a toolkit. So the document that you have on tables, it presents the Theoretical Domains Framework in the different categories of where the barriers to VR can be located. And within the table that comes also below, you have some examples of questions for each of the domains. So essentially to help you think through the different barriers that might be encountered in a more systematic way. So essentially by using a tool like that, you're kind of making sure that you don't miss anything. You're having a more systematic approach to exploring what is likely to influence implementation. And when you ask those questions, you have to be mindful of who are you talking about and the perception of who. So like we said earlier, there's different people involved in the implementation of VR, whether it's a nurse, whether the patient in itself, a manager, conseillère en soins infirmiers, you have different people. And you have to think through also, okay, what do people at different locations within the unit or the hospital think about VR? So for those different questions as well within the document. So essentially, it's a framework for thinking about what is likely to be helpful or not so helpful around implementation. I put in as well an example in the document of the use of the TDF framework for the implementation of therapeutic VR. I think this is for mental health problems. I wasn't able to find one application directly for pediatric contexts. But I think it gives an example of, they stratify essentially different barriers around capability of people involved in delivering VR, the motivation of people that are involved as well, and whether or not they have the opportunity to employ VR within their specific context. And they classify, is it a barrier, is it a facilitator, or is it a mixed factor? And this is, I guess, a bit of a more advanced, geeky thing around implementation science. But what I like to do is that when you identify, different barriers and facilitators to implementation, not necessarily, when we'll do research and full-on implementation science, we'll categorize and attribute values to different barriers and facilitators. So is it a major barrier, a major facilitator, or is it a mixed factor, or in between? So you don't have to do that, but you have to think through, are these barriers addressable? Which ones are addressable? Which barriers should be addressed first? So you have to think through, those kind of barriers in the process. So of course, some barriers are, you need to address them. So people need to have the skills to use VR, need to have the knowledge on how to use VR. So lack of skills, lack of knowledge, you have to address. Whereas, you might have some, I don't know, negative or, unsure, people are unsure about the benefits of VR. So again, that can be easily surmountable, as a barrier. If you lack staff and you have like no nurses, one nurse for the whole unit, you won't be able to bring in, a dozen new nurses. So it is a barrier, but it's not so addressable. So you have to think through, okay, those barriers exist, but which ones can be surmounted and which strategies. So essentially, when we do implementation science, we do this really systematically, kind of classifying all those barriers. But I guess this is just a way of thinking around, how do you prioritize the different barriers and which ones you're going to address. So once, you think through some of the key barriers, which ones are most important, which ones are addressable, then you think through the strategies. So implementation strategies. What are implementation strategies? So they're methods or techniques used to enhance the adoption, implementation, sustainability of a program or clinical practice. Within the last decades, there have been many different lists of implementation strategies that have been proposed by different researchers and different implementation experts. I would say that the first one on the bottom left is the one that is most used today. So it is called the Expert Recommendations for Implementing Change taxonomy. So within, as well in the document that I've circulated, you'll see some different colors on the last few pages. So those are the list of strategies within the taxonomy that we'll be talking about a little bit more. So the choice of implementation strategies, it's a bit tricky because there's no magic bullets, right? So all strategies work some of the time, but you have no strategy that works all the time. So you need to find the right strategies for your problem and your context and your innovation that you seek to implement. And the choice of implementation strategies should be based on what are the barriers, that your knowledge of the barriers, should be based on the resources that you have within your setting, should be based on, is it practical, is it logical to deploy the strategy? And you can also I'll present some evidence regarding the effects of different implementation strategies as well. So your decision-making process should be a combination of those factors to guide which strategies you're going to use. The strategies can be discrete, so that means we'll have one strategy. It could be we're going to implement VR just by doing an educational workshop with people. So that's one strategy. Then we're going to do a workshop, and we're going also to develop tailored educational materials that we're going to distribute. That's a second strategy. Then we're going to do the workshop, do the materials. We're going to have champions on the units for VR. That's a third strategy. Then we're going to, as well, audit and feedback. So we're going to see, the extent to which inpatient file VR is being used, and then we're going to provide feedback to clinicians to promote the uptake of VR. That's a fourth strategy. And then we're going to distribute an educational leaflet to patients about VR to tell them to ask their provider about VR. That's a fifth strategy. So strategies, they're like that, So you can have a discrete strategy, but you can have a combination of strategies. And we call those multifaceted implementation strategies. So usually those strategies as well, they can address a range of factors, and we'll talk through some of those examples. So this slide is a bit weird, but we did a systematic review of the effects of implementation strategies on nursing practice and clinical outcomes. So with over 200 studies, looking at the evidence across the globe. So which strategies are used and what is the effectiveness of those strategies? And without surprise, the main strategies that are being used are educational strategies. So educational meetings, educational materials, clinical practice guidelines, audit and provide feedback, reminders at the point of care to remind people they're opinion leaders, champions, Educational outreach, so that's somebody going into the clinical practice setting to do one-on-one coaching with a nurse, for instance. Tailored interventions. Tailored interventions, they're essentially doing an assessment of barriers and looking what works best for the given setting. Patient-mediated intervention. That one is the example that I gave of distributing something to the patient who then asks the provider to use VR. And then essentially you have, what? 1, 2, 3, 4, maybe 10 strategies, around 10 strategies that are used more than in 5% of studies out of the 200 studies. So that tells you that, a small subset of available strategies are being used to promote evidence-based practice, right? Only like 8 or 9 types of strategies are really being used. Whereas if you look at the evidence base available, you have in the ERIC taxonomy 73 different strategies across 9 groups. And this is the taxonomy, the list of implementation strategies that is the most common globally today. That's being used to promote the uptake of different innovations, including digital health innovations and other innovations. So that's the whole list, So we have 9 groups of strategies. We'll walk through some of those groups a bit more in detail. The first cluster or group of strategies is evaluative and iterative strategies. So those strategies, they're really focused on essentially evaluating the context of implementation. So, you want to implement VR and you're not sure how best to start. Well, it's often useful to just, assess whether the setting is ready through, for instance, a questionnaire or an interview, and then look at the barriers that are in the setting. And then you have some additional strategies that are within this cluster, which seek to essentially stage up the implementation process. So often one of the other strategies that is being used within this group is strategy 8, starting small and then gradually leveling up and including other settings for the use of VR, for instance. Another strategy that's very common in this group is obtaining and using patient and consumers' feedback on VR, and that can help change the way that we're deploying VR in a given setting. Then you have group 2, which is around providing assistance to the clinicians. So that will often be, 2 things. So then having a clinician, an external person, providing some facilitation to clinicians to use VR, for instance. Another thing would be around having some centralized technical assistance to make sure that if problems come up around VR, that people are, they have a resource that they can get to, that they can call, or some technical support. Third group of strategies is adapting and tailoring the innovation to the context. So, you have a protocol for VR that's, successful, that's Shusen, you want to bring it here, or vice versa. What do you need to adapt to the protocol to make sure that it is suited to the context? And adapting to the context and tailoring, you'll have a likely more chances of success. Then a big group is developing essentially the interrelationships between different stakeholders for implementation. And that often involves identifying, who will be the early adopters, who will be the champions, identifying also who will be part of the implementation team. So this is also critical as well, and you have a range of strategies within this group. Then one group that we do know really well is training and educating stakeholders, right? So, conducting ongoing training, providing ongoing consultation, educational materials, train-the-trainer strategies. So people who have trained for VR, they can train other people once they've been trained to use VR. Working with some experts, creating a learning collaborative for VR, for instance. So you have a range of different strategies that can be used as well within this group. Group 6 is supporting clinicians. This is often 2 things. So around, revising how the roles are set up. So to integrate VR into the roles of some people. It could also be around reminding clinicians to different types of reminders that you can implement, or supporting professional roles in other ways, like making sure they have access to clinical data to support implementation. A group that's critical is engagement with consumers, so group 7. So having some of those strategies that do involve patients, and essentially you distribute some materials, you have some strategies that are tailored to patients, because there's some good evidence showing that those are some of the most effective strategies when you mobilize patients to change the practice of the provider. So that's a key group as well. Group 8 is financial strategies. So essentially making sure that you have the resources, the financial resources necessary for promoting uptake of VR within your setting. In some cases, incentives can be implemented, but sometimes it's not applicable to the given project. And then the last group is changing infrastructure. So essentially, within the setting, do you have access to all of the proper equipment for VR? Do you need to change the way that the physical environment is set up to make sure that people are able to use it properly, and other similar strategies? So these are the 9 groups of the ERIC taxonomy. And if you look at, I think what's interesting is to look at the effects, the effectiveness of some of those strategies to promote the uptake of innovations. So we do have, a range of systematic reviews within the Cochrane Effective Practice and Organization of Care group. They do some large systematic reviews on the effects of different implementation strategies. So for instance, if you distribute educational materials to nurses in a given setting, the effect that you can expect is 4% more compliance with desired clinical practice. If you have local opinion leaders, that 11% more compliance with clinical practice. If you have educational meetings, 4%, educational outreach, 4, 6, and then reminders, you can see 11, 8.45% for the other types of reminders. So I think a few things that's interesting to consider. First is, this is the effect of one strategy. And we talked about having a combination of strategies. So the effects of those strategies can, of course, add up, right? So, if you use a combination of strategies, like a package of 5, 6, 7, 8.
Add up? Yes? They add up?
That's what I was, I'm getting at something.
Okay.
Yes.
What about clinical practice guidelines?
There's some reviews around that. It's similar to educational materials in terms of effects. So a few things. So first, multifaceted strategies, they do have larger effects than a discrete strategy, but there's a ceiling effect, right? So of course you won't have a gain of like 70% necessarily because you're using a bunch of strategies. So you have to think about the context, and the effects will be dependent on the setting and a range of factors. But it's interesting to consider as well the volume, So somebody was saying, oh, we're using audit and feedback and it's only a 4% gain. But they've used audit and feedback, across the United Kingdom to reduce antibiotic prescribing with physicians. And at scale, 4% is how many people across the country? It's enormous, right? So the volume of patients is also, the volume of the clientele is also important to consider when you look at these effects. What I think is also interesting is to consider this. So they've asked like 200 implementation science experts to look at all of the strategies that I've presented. And regardless of the context or what you want to implement, what are the strategies that are most feasible and what are the most important? And I think it's interesting to see that the green quadrant represents all the strategies that are perceived as being very important and pretty much feasible regardless of the context. For instance, developing educational materials, something we almost always do. Something that we do, quite less is developing a formal implementation blueprint. So having essentially, what are the different steps for implementation? What are the strategies that you need to, have for implementation across the different steps? So essentially a very detailed implementation plan. Conducting a local needs assessment, so to making sure that you really understand the needs of the setting before putting an innovation in there, right? And then assessing for readiness and barriers and facilitators like we talked about, then audit and feedback. So it's interesting to take a look more specifically at the strategies that are in the green quadrant first and foremost. So that's the whole list of strategies. And then I think a tool that's really interesting is the Center for Implementation. They have an online tool that's quite new. I think it just came out, called Strategies. And then they have the theoretical domains framework. So if you think the staff is going to have lack of knowledge, lack of skills, you click on essentially those bubbles, and then it brings you to some potential strategies on the tool as well online. Because it is quite complex to link strategies to barriers, right? You do have, you have to think through the barriers quite carefully. So often there's two ways of going about it to map the best strategies to the barrier. The first method is using those types of tools. So, going online, and what they've done is kind of use the evidence and the theory to kind of map ideas of best strategies for each barrier. So that's one way of going about it. But the second way is the common sense approach and the consensus approach. So the best way to go about it, usually to map the best strategies, is have a group discussion. So, leveraging the barriers and facilitators that you know of, that you've assessed, thinking through as a group of those barriers, which one we want to prioritize. And then we look at the menu of strategies, and then we look at maybe the output of this tool that I'm showing, and then we take some decisions regarding, what are potential strategies to promote VR in a given setting. And I guess to conclude, we also have to think about, we have one strategy, which is having some workshop or an educational meeting, for instance, or educational materials. But you have to think through what will the strategy look like in practice, right? So what are you going to do exactly? If you're going to have some champions or providing some audit and feedback, over the course of what, time frame, how many times are you going to do it, who's going to be doing that strategy. So essentially you kind of need to be thinking about, okay, who's going to be doing the clinical act, and then who are going to be doing the strategies, right? It's kind of the two pieces of the puzzle. And I guess that you also have to think about sustainability. So the strategies that will be deployed first with some meetings and things like that, and then what types of strategies will you be considering for sustainability. So I guess the last part of the workshop is about thinking through the barriers to address, the potential strategies to address as well, using the tool that we've provided, and the implementation plan template that Arjuri and Sophia have put together with the QR code, and answering those questions, questions 22 to 41 in the survey. So yeah.